So after our presentation, very interesting presentation on rules, collaborations, harmonization to improve access to precision testing, now we start with the discussion, the panel discussion with our speakers and chair. Dr. Fusco presents us an overview how to enhance collaboration between pathologists and molecular biologists, also to stress the point of how we need the multidisciplinary approach to the next generation pathology. Then Normanno present us the EQN Path SPC EPFA project on to recognize and to analyze the different variation across the Europe about the quality and access on biomarker tests in Europe. Dr. Paulmichl present how we need the regulatory perspective, the guideline and the policy associated to the tests associated with drugs, what is realistic, what is need to improve. And at the end, the last, Dr. Frattini discussed about the barriers that need to be overcome, the fifth barriers that we now to face to give the more accessibility to precision testing in general and Europe especially. So, Dr. Frattini, if you want to introduce about you and you as a co-chair, please.
Good morning, everyone. Fortunately, I was here late, but all the presentations were very nice, and I see that we can greatly improve our daily experience by sharing our experience and discussing how to improve and how to be more active and more able to do better diagnosis every day.
Thank you, Milo. So I want to start with Dr. Fusco because Nicola, you speak about the role of the next generation pathology, the need to have a multidisciplinary approach, not only about the pathologist and molecular biologists, but also immunologists, genetics and technician. Of course, you stress also the technological heterogeneity, the intra-tumor heterogeneity, but I want to know from you what is about the technology and the expertise and the skill that each specialization required to put their contribution in the new next generation pathology. If there are some suggestions from you, from your experience, how to try to manage the complexity of this different approach, different background, to have a very good relationship among these professionals, and what is the best workflow to involve them in biomarker testing, also to increase quality and access. Please.
Thank you, Pietro. Thank you for your question, and thank you to everybody for being here, and good morning to everybody. Yes, your question actually fits perfectly in this next generation year that we are living, because I am a pathologist. I'm a pathologist with a particular interest in molecular pathology and biomarkers testing. And actually, I've seen that the role of pathologist is rapidly changing, especially for those pathologists who works in the field of oncology, because yes, the diagnosis remains central, but now we are experiencing an era of great changes in which the diagnosis of the disease is not enough. We have to pair with the diagnosis and cope with all of the biomarkers assessment, because biomarkers are the base for the definition of precision medicine. The point that I would like to stress here, and also I would like to see your opinion about that, is that precision medicine, in our opinion, in our approach that we do at the European Institute of Oncology, it should be based on the tailoring of the testing itself, not only the tailoring of the therapy. Because, as you mentioned, Pietro, we have several types of heterogeneity that we have to deal with. So first of all, we have the biological heterogeneity, the intratumor heterogeneity. It should be addressed, and in particular in the setting of what type of specimens we have to analyze, because also specimens are extremely heterogeneous. Primary tumors from a surgical excision, for example, of a breast cancer, and a small biopsy or cytological sample are totally different and require totally different approaches. The point here is to select the appropriate biomarker testing strategy, also in terms of technology. And another phase that we are experiencing this era is the great technological heterogeneity, meaning that one biomarker can be tested using a plethora of different strategies, and most of these strategies can be even CAIVD or FDA approved, because we have heterogeneity also in the companion diagnostic test. So how to choose the best diagnostic strategy at a single patient level? I believe that, and I think that everybody agrees now, that multidisciplinary collaboration is essential. We have to merge all of our skills, of our knowledge with all of our collaborators. So pathologists, molecular pathologists, molecular biologists are essential in this workflow, and molecular technicians as well, and clinicians also. So we have several types of professionals that should collaborate in order to provide the most specific and precise testing strategy for that specific patient, and also in that specific time, and I would also say in that specific clinical reality, meaning that something that is good and is optimal in one hospital can be radically different in other hospitals. And then also the terms of the issue of the reimbursability and the costs of this test. And of course, this requires an optimization of the lab workflow and the working procedures. And for this optimization, we really need that pathologists and molecular biologists we work together and collaborate together. Otherwise, it would be extremely difficult. Our job is already extremely difficult if you are not able to collaborate and communicate with molecular biologists, with technicians, and with oncologists. It will be a great challenge to reach the precision medicine scope. So this is my view, and I tried to stress this in my presentation, because the changes that you are experiencing in the field of pathology oncology are exceptional, and it's a great opportunity. We have been able to get this opportunity and to take this opportunity. In this setting, multidisciplinarity inside of the lab, multidisciplinarity within multidisciplinary meetings, and molecular tumor boards are key, in my opinion.
Thank you very much, Nicola. We have two hands raised. Please, Marcus Paulmichl.
Nicola, thank you for the nice introduction. I guess you stressed rightfully that there is a multidisciplinary approach in the area of personalized medicine. However, I missed one professional figure in your group that you mentioned, and I guess for the personalized medicine, the therapy, besides the surgery, is a pharmacological one. So I guess extremely important in this area of personalized medicine is the pharmacologist, and I guess especially the pharmacogeneticist. Now, I do agree that this is a poorly defined figure at the moment, and I guess there is possibility, most probably, the need to define that figure a little bit more in detail. However, the pharmacological approach is an important one. Now, I don't think that the histology agnostic approach in oncology is going to be the winning one. I guess histology still will be a very important part of it. But I guess the other part will be the therapy, or choosing the therapy according to the different biomarkers. And I guess here, pharmacologist is a very important addition to the group that you mentioned. Thank you.
I totally agree with you. I totally agree with you. And on the top on what you said, I have to tell you that our pharmacologists are parts of the molecular tumor board and are parts of the multidisciplinary discussion. And that's an extremely important figure, particularly in this era in which we are living with histology agnostic therapies. And in this setting, even when we talk about, for example, target therapy, immunotherapy, we are talking about a constellation of different types of therapy. And these settings, in this setting, is extremely important the professional of and the skills of the pharmacologist.
We miss you, Nicola. Now I want to give the words to Milo Frattini. Please, Milo.
Well, I totally agree with these points, but I would like to focus my attention, essentially because I'm a molecular biologist, on tumor heterogeneity and the technical approaches. If we apply for many markers, we have different techniques characterized by different sensitivity. And of course, if you apply the technique with a higher sensitivity, you can find mutations in or alterations even in only few cells. But what's the clinical relevance of these few cells? For example, if I focus on colorectal cancer and in advanced colorectal cancer for which the EGFR targeted therapies are available and for which the RAS testing is required, is mandatory before the administration of these therapies, if you apply a very high sensitive methodology enabling the identification of RAS mutations in less than 1% of cells, at the end, the sample is characterized by positive for the presence of a mutation, and therefore the patient is not treated with that therapy. But 1% is an example, of course, means that there are 99% of cells that are RAS wild type and that can profit from the administration of therapies. So, and to date, we don't know what's the best technology, what's the best cutoff for sensitivity for every analysis. So probably the future would be to define better these cutoffs in order to probably also better treating the patients, because I don't think I completely agree, and it's well also demonstrated that tumors are heterogeneous and not homogeneous. Therefore, probably different types of therapies fighting against specific cells would be the best approach for the future.
Thank you, Milo. Nicola Normanno, please.
Yes, I just want to raise a point. I fully agree with Nicola that then the organization must be adapted also to the local organization of the different centers that are testing. In our molecular tumor board, I mean, I think we have a number of figures, but I think there are a few figures that are essential. You need to have the molecular biologist, the pathologist, the oncologist, and we have our pharmacist also, because at the end, if you want to get a drug, you need to go through the pharmacy. However, what I want really to raise is the importance of bioinformatics. I mean, I don't know what happens in other countries, but at least in Italy, we are struggling finding people that has experience in bioinformatics. And actually, with increasing complexity of the data that we will need to elaborate, and this is also in relationship with the tumor heterogeneity as introduced by Nicola and also Milo. I mean, it will be always more and more important to have a good bioinformatics in order really to provide an interpretation of the data that we find and the possibility then to use this information in order to suggest a possible therapy. And this is actually limited. So I think, I don't know what happens in other countries, but I think we should have a clear investment in training people with the experience in bioinformatics, because this will be really the struggle, the bottleneck in development of precision medicine.
Thank you, Nicola. Now, Marcus, the floor is yours.
Okay, so Milo, I guess, you know, the points that you touched are utmost important. And I guess the heterogeneity is a nasty thing in this whole diagnostics. However, and I've totally agreed that we need to have rules and workflows in order to do the respective analytics. I guess one way for sure, in order to integrate the different, the heterogeneity of the tumor itself, is going to be the liquid biopsy. And I guess there, of course, the cutoff is going to be very important. And I guess the technical aspects of the analysis, they are going to be increasingly important. Even now, if labs are only using PCR, there are so many setbacks and difficulties, like allele dropouts and so forth. I guess people are not aware about the technical complexity that we encounter. Nicola, to your point regarding the bioinformatics, I guess, I mean, I'm working now for 10 years in the area of pharmacogenetics. And I guess at the beginning, I thought, and that was for sure a mistake of mine, that we need to educate our colleagues in pharmacogenetics. Now, this is not going to work. We found out that there is too little time available for our colleagues to really catch up and get up par. So I guess the whole problem of the bioinformatic issue is only going to be solved if we have IT-based tools at hand, where the computer basically is taking over the huge amount of information that is around and is just boiling it down to that information that is important and valuable for a specific patient. So I guess there is quite some space and room for developing new tools in order to make this work more accessible to different colleagues.
Thank you, Marcus. Milo, do you have your hands raised?
Well, I have two different comments on the various good statements I've heard now. The first is the need of bioinformatics, for sure. It's not easy at all to investigate and to find out the results from very large panels. And very often now we are faced on with very large panels, and the identification of mutations in not completely known gene is of highly relevance, I think, especially, for example, to HRD panels, and where a lot of genes can be involved and for which the specific clinical relevance is not known. In addition, clinical relevance is going to be the most important thing in the future, because now the oncologists don't want only to know if one mutation is present or not, but they want also to know what's the clinical relevance of our alteration. Essentially because most of the genes that are now investigated are without therapy or can be a target for therapies, but very often we have difficult interpretation in the type of mutation. Very often we have a variant of unknown significance, and therefore the oncologists don't know if what we identify in a lab is true. So that means it's a true alteration or not, or it's a sort of polymorphism variant with not clinical relevance and so on. So that's a good point, I think, that in the future will be one of the cornerstone of our analysis. The second point is liquid biopsies. Well, I completely agree that liquid biopsy can bypass the problem of the need of tissue and can identify alterations coming from multiple lesions. However, if we want, that's very nice if we have to identify new mutations. But if you want to monitor over time in the follow-up the different lesions, it could be not properly perfect way of the evaluation, because you can see in general if that mutation decrease or increase, but you don't know if there is heterogeneity in terms of lesions. That means you have two lesions with, for example, EGFR mutation and two that are wild type. Therefore, the clinical appearance of the clinical follow-up of the lesions can be different, and the liquid biopsies the analysis of liquid biopsies cannot properly study the picture of that patient.
Thank you, Milo. Before to left the words to Nicola, I see also the end of Marcus for last comments about this presentation. Then, Nicola, you can summarize on your point of view. Please, Marcus.
I guess, Milo, what you said is very important. I guess I didn't make the comment of liquid biopsy because I think that that's the holy grail. I guess what we are going to experience in already now and in the future even more is that we need an array of different techniques in order to tackle the problem. So I guess neither the liquid biopsy nor the histology or whatever is going to give us the definitive answer. So we need to put the different approaches together into a smart way. And I guess the other thing that you mentioned is going to be just increasingly important since a lot of labs use sequencing approaches, and we do identify new mutations that we don't know the function. Now, I have to apologize that I'm going back to the pharmacogenetics again, because that's the area where we work, and I guess we identified that as one of the major problems. So let me talk about a very polymorphic gene, the CYP2D6, where we identify almost every week a new mutation. Now, we developed in the lab a functional test where we can assay new mutations in a human cell-based system. And I guess that's a very important issue, because if we bounce back to the colleagues a report with a new mutation and we don't know the functional implication, our colleagues are going to be overwhelmed. We need to find out what those mutations do. And I guess a shortcut that a lot of labs use in order to not report on those mutations is the wrong one. We need to report what we find, and we need to make sure that we find out ASAP what the functional implications of new mutations are. Thank you.
Thank you, Marcus. Nicola, please.
Yes, thank you. And I totally agree with Milo when he says that the type of mutation is extremely important to assess the functional consequences of a mutation is not easy at all. And that's why, as Nicola mentioned, the bioinformatician is a key figure in the multidisciplinary meetings. I think that we also struggle in finding good bioinformaticians, skilled bioinformaticians. I think that one of these reasons, the reason why we struggle so much to find someone for this role is that in general, and not in all countries, there is a specific academic formation for these professionals. Now things are changing, And I think that this will help us overcome this issue. But yes, I totally agree with that. And this is extremely important given that, as also Milo mentioned, we are moving from an era in which it was one gene, one biomarker, now is one mutation, one biomarker. Each mutation is different from another one. And on the top of all of this heterogeneity in the type of mutation, in the type of technologies, in type also of the professionals that are involved in these multidisciplinary discussions, we have also a temporal heterogeneity. And that's why the challenge of liquid biopsies comes up, because particularly in many tumors in which now we are having target therapies that we never had before. For example, breast cancer, after anti-HER2 drugs, we never had in clinical practice target therapies. Now we are having new target therapies in the metastatic setting with alpha selective inhibitors of PI3K. This is just an example, but these patients are long survivors. So the type of mutation, the type of tissue, meaning the primary tumors, testing the primary tumor, testing the metastasis, testing the liquid biopsies requires a specific workflow. So I agree with all of you when you said that we need to come up with workflows. So we have first-line testing strategies. Then, in case of negativity or in case of unknown significance of the alteration, we can go with other testing strategies, both in terms of technology and in terms of type of biospecimen to be tested.
Thank you, Nicola. I want to pass the second presentation about the project on assay quality of biomarker in Europe from Nicola Normanno, the important project held from EQN, PATH, ACPC, EFPA. I think that after 20 years of molecular oncology, now we are facing different, very important steps forward to have a holistic approach.
Salut, comment vas-tu? Très bien. J'avais dit 11 heures. Là, je suis quand même.
Hear you, Mati, please.
Oui, oui.
And now we know.
Non, je suis à distance. Non, je suis à distance. Le lundi, je monte jamais à Genève, sauf exception, bien sûr.
Please close all the microphones. Please close all the microphones.
On peut se connecter en vidéoconf. Je t'envoie.
Mati, please.
Pardon? Non, je t'envoie une demande Zoom dans 2 minutes. À tout, ciao. Ciao.
Mati, we hear you. Please mute your microphone, please. Thank you.
Sorry.
So now, after the outcomes that Dr. Normanno presented us about the outcomes of the project present significant variation in the drug and test access as well as quality across Europe. So we discussed about the role of among the specialists, the technology, but in Europe now we are assisting a different variation. And also Normanno presents short-term policy recommendation, long-term also for the future. Nicola, for your point of view, what kind of action in Europe we can propose, for example, from a bottom-up strategy or top-down strategy, and what is your roles as a specialist to help the institution to have a better standardization to improve the access and the quality of the test biomarkers and drugs? Please, Nicola.
Yeah, Pietro, I mean, it's difficult because I think that to address your question, because really the barriers are different in different countries. So really what we are now doing is to discuss in each country and try also to adapt the recommendation to the local situation. I do think that we need an approach that is top-down. I mean, I think we should have some strong recommendation, strong position from the European Commission in order to make clear to everyone that we need to give the possibility to our patients to access high-quality biomarker testing. What I'm trying to explain to different levels is that, you know, we have focused the organization, our system on the drugs, but now we know that for precision medicine, the biomarker test is equally important as for the drug. And if you do not have access to a biomarker test, as a matter of fact, you will not have access to a number of drugs that do require biomarker for testing. And this actually is what we found in many countries. What happens in most of countries that the approval of the drug and the approval of the test are not linked together. And so what happens is that you have the drug that is approved, but you don't have access to the drug because the test is not available. And this is something that could be simply solved because it's a matter of organization, it's not a matter of putting money into the system. But as you know, in some countries, including Italy, it's much more difficult to change the organization rather than maybe buying a new NGS machine. In some of the cases, however, we have clear problems of capability. For example, in Eastern European countries, there is a low capability for NGS. So do we need to have centers that we establish centers that can really test for biomarkers, even for more complex biomarkers. Even in Western countries, we have an uneven distribution of labs. For example, in Italy, there's a clear gradient going from northern to southern Italy with a low number of labs testing in southern Italy. And some countries, as Italy, Spain, and other, is quite surprising that still the access to single biomarker tests is limited. I mean, for some single biomarker tests, either the pharma companies need to pay or the patient has to pay with out-of-pocket money. And this, of course, is not acceptable because, at least in Italy, we have a system that wants really to provide all types of therapies to every patient. But if you don't include also the cost of the test, that sometimes is really marginal, sometimes it's simply immunohistochemistry, that, as a matter of fact, you don't put the patient in condition to receive the test, the drug. So I think that we really need an action at European level in which we need to establish some main principles on how biomarker testing should be organized and should be offered to patients. And then we need to go to single countries in order to identify the specific barriers and work in order to remove such barriers.
Thank you very much, Nicola. For your perspective, do you feel that it could be useful to sharing the best practice? Because in your presentation, some European countries are best compared with the others. So, for example, in a benchmark activity that could be useful for the European Commission to extract the best practices and to have a common standardization, as you said, top down, but also adapted to a country level.
Yes, Peter, exactly. This was one of the points of our research. Indeed, for example, the problem of the approval of the drug and of the test has been solved in, for example, in Belgium, in which they had now a mixed committee that includes both, let's say the people who are in charge for the approval of the drug and people who are in charge for the approval of the test. In Italy, it takes 5 years before we approve a new test, and this is not feasible. Something needs to be changed because with the speed with which precision medicine developing, actually fortunately developing, I think that we need to adapt this. And so the idea is also to present some example of good practice. One is Belgium, also Germany and others, in which some of the problems have been already solved. And so I think that we can take inspiration from these, and hopefully we will try to convince also politicians at European and national levels to come with a recommendation that should be really reinforced in every country. Then if you go to a single country, sometimes the problem is really of structure. So for example, in some Eastern European countries, it's clear you need new infrastructure, you need to create labs, you need to train the people, and to make the possibility that even patients can access to tests. We really wanted to have patients also involved in this project, because sometimes when you go to a reference center, even in Eastern Europe, and you ask if they test for all biomarkers, they will say yes, and that's true, because they will test all biomarkers. They're very good, they can do NGS, whatever they want. However, then you discover that the patient maybe has to move by himself 200 kilometers or 300 kilometers to bring the sample to the center to be tested. And so as a matter of fact, this is a huge limit for the patients. So it's clear that we need an organization around biomarker testing. My vision is that we cannot have too many labs testing. In Italy, we have maybe 150 labs testing for RAS mutation. We don't need 150 labs, but we need region. In Italy, we are organized as on a regional basis for the health system. So we need regional networks of labs that can really take in charge of every patient that needs a biomarker test in order to give these patients the possibility to receive this test. And then, of course, I'm talking about clinical practice, because clinical research is something different, although we are in a phase of precision medicine, which clinical research and clinical practice are really close one to each other. I mean, a few years ago, maybe when I got my degree as a medical doctor, it took 10 years, 15 years before a new discovery could get to really in a two therapy for the patients. Now, in a few years, we really move from the bench to the patient. And so, really we have a huge overlap now between clinical research and the clinical diagnostic. And this also should be taken into consideration when we organize our system.
Thank you, Nicola. I see the Marcus and Wes. Please, Marcus.
Nicola, thank you for your remarks. I guess your idea, that the whole regulation should be a top-down, is very much appreciated. I guess the one problem that we face in Europe is that Europe is so heterogeneous. And that makes it really difficult to enforce certain rules. However, EMA is giving advice and is issuing guidelines. And those guidelines should be followed. And I guess I need to stress that, especially guidelines in the methodology field, the EMA is not only the authority until market authorization, but with the pharmacovigilance, EMA is overviewing the whole life cycle of drugs, and therefore the normal testing after market authorization for the different drugs. And I guess those guidelines that are issued should be followed, because as I stress in my presentation, only the right analytics can be clinically useful. If the analytics is not done in the right way, if there are inherent flaws and in the analytical pathway, then the result is really not helpful. It can also be dangerous. So I guess it is necessary to follow those guidelines and to deliver a result that can be executed and is safe for the patient.
Thank you, Marcus. Nicola Fusco, please.
Sorry. Thank you, Marcus. I totally agree with you that the analytics is essential. And also, as Nicola was saying just before, we need to centralize at least the most complex analytics in labs with the appropriate skills, but also the appropriate workload, because the optimization of the lab is essential. And in this respect, I would like also to add an opinion on the importance, given that the analytics should be centralized, at least at some extent, of the pre-analytics that regrettably cannot be analyzed. And that's why I totally come with the point of Nicola that the education and the continuous quality control, quality assessments at the local level remain crucial, because there's when we talk about precision medicine, we have also to talk about the imprecision of precision medicine, meaning that if the input is not good quality, then you can have the best core lab in the world, but the output cannot be as good quality as we need.
Thank you, Nicola. Milo, please.
Well, I agree in general about the need of centralization, because in this way, more trained people can provide a better estimation of the analysis. However, there is also the need for local laboratories to know about the analysis in order to have a better discussion with the local molecular boards. So there is a sort of dichotomia about the need of centralization, but on the other side, to have highly trained labs local in order to provide good results and to discuss with the oncologists, because if all the analysis, or at least the largest analysis, are centralized, it's quite unfeasible that these central labs can have an interaction with all the oncologists. So it's quite difficult now to have the good way. For sure, centralization is one way, but I don't know if it is the best one.
Can I reply to some of these comments, Pietro?
Absolutely, please.
Yes, I fully agree with Marcus that EMA rules should be followed. However, I remind to everyone that we started with EMA when they approved the first drug based on genomic testing. They approved EGFR monoclonal antibodies for KRAS wild type patients, which means really nothing. So it took time before also EMA started at least to give some more precise advice on what has been done. But when I say top down, I'm just going to just make an example. The participation to external quality assessment schemes is not mandatory in the majority of European countries, which means that there are a number of labs that never participated to an EQA, and for several reasons. One of these is also because if the participation is not mandatory, you don't have budget to participate. So this is one of the limits. But still, there are also some private labs that do not participate to any external quality assessment scheme, and they continue to test patients. And maybe if they have an error, they will give a lot of false negative or false positive. This is why I think that there are some points in which we need some rules that come from Europe and need to be top down. This is an example. All labs that want to run a genetic test or pathology, molecular pathology test, they should really participate to EQA schemes. On the other hand, for the problem of centralization, I think that there is never a solution. However, I think that we do need to create networks. If we create networks lab, even the peripheral lab will be connected to the central lab who is doing the most of testing or more complex testing. And of course, we need to agree also on the pre-analytics with these labs, because if we receive material that's not suitable then for testing, as Nicola Fusco was highlighting, at that point, it's unuseful to have a very good centralized lab with NGS technology if he receives material that's not adequate for testing.
Thank you very much, Nicola. I have a question for Marcus. For your presentation, Marcus, you explain, you stress the need of the policies to add the adoption of a personalized and individualized medicine, and also the role of guidelines. For your perspective, for your experience, what is the needs that we need guidelines and policies for the future, in the short term? You say that no indication on how the test should be performed. So for your experience, what kind of policies and guidelines we need in the short term? Please,
okay, so I guess the methodology used for the diagnosis is going to be increasingly important. I mean, we move away and into the field of molecular diagnosis. And I guess EMA is actually taking care of this new development. The structure of EMA is going to be revisited and restructured. There will be a whole working party, so to say, for methodology questions. So the way how analyses are done, not only in the wet lab, but also on the bioinformatic level, on statistics and so forth, design of clinical studies and so forth and so forth. I guess there will be a whole new array of guidelines issued in the upcoming time in order to help labs and clinicians around Europe to perform meaningful studies. And I guess that's going to be a very important point. Those problems cannot be solved on a national level. They need to be regulated from, or in all the countries need to be, similar regulations. And therefore, this is for sure a whole new challenge, for the Europe as a whole.
Thank you very much, Marcus. About the last presentation from Milo Frattini, the barriers they need to be overcome to improve the access and the quality. Milo, you stressed 5 barriers. The first was the type of materials. The second, the type, the costs, and the markets, the types of markets, the workflow of specific tumors, and the training. But from my experience, my opinion, that we need also to add a sixth barriers is about the cultural, the awareness, the knowledge. In other words, the education, not only from the specialists, but also from the main stakeholders. For example, we didn't mention the general practitioner in molecular oncology is fundamental for the patient access to this kind of test and drug. And for your experience, these barriers, we also discussed about the policy and the guideline, the next steps that we need to address to have a better access and quality. For your experience, is a cultural remain a barriers not only among the specialists that are firstly involved, strictly involved in molecular oncology, molecular tumor boards, but also the stakeholders that, for example, the policymakers, the patients, but also the civil society about the needs to improve molecular oncology, the next generation pathology. So, what do you think about it?
Well, as for another field of the vaccination with COVID, there is a sort of distance between clinicians and patients or the general population. And we need to increase the knowledge and there are a lot of people that now go on internet and ask directly the analysis and know very well what they are asking for, the oncologist and so on. But the majority of patients are quite passive, and also the general population is passive, is not active in that process. And unfortunately, there are a lot of clinicians that very often doesn't know very well what are the alterations that are identified in a sample, especially if the alterations are in rare genes. Therefore, the future would be to expand this knowledge to all the population and to be more scientists in every field of our life, and therefore to know better what is required by clinicians, what are the consequences, because very often we can also have some analyses that are not relevant, but they are very expensive. Therefore, we lose money for not required, not mandatory analysis. In addition, we have also to be strict with the rules. I cannot understand why some laboratories can provide a complete molecular characterization without the participation to quality controls. It means that it's a sort of, you don't go to the car machine to check if your machine is well or not. You must check your car when you drive, as you must check your lab is fitting well or not during the characterization. So therefore, we must remove these labs and to focus all the money to labs who wants to increase in knowledge for themselves and also for the patients.
Thank you very much, Milo. For sure, remains a lot of to do to improve the molecular oncology in this new era about mutational model, and the next generation pathology. Of course, we need to also do sharing the progress as a SPCC we are doing with kind of project. Now we are closing. If there are not other question or comments from our speakers that I want to thank, because you are very vibrant, this very participate session, also our sponsor for supporting us for this kind of project with our Institute West, of course, thanks to all our audience. And I think that today we touched the all important points about the rules collaboration and harmonization to improve access to precision testing that also related to the precision therapy and individualization and personalization in oncology. So I want to thank all of you, and we will see the next project. Thank you very much.
Thank you.
Thank you for the very helpful discussion, and Chair from Switzerland.
Thank you to all.